Today, we're going to talk about supply, distribution, and migrations of physicians in Canada. I would like to acknowledge my co-authors, Hetal Dave and Deborah McCartney. We're going to see the presentation outline quickly, background and context. We'll continue with objectives and then move to data and methodology. Following with results and finishing with interpretation and policy implications. Okay, background. Access to physician services has been an issue for a long time in Canada and is becoming more topical due to the COVID-19 pandemic. It's essential to provide decision makers with reliable and up-to-date information on key characteristics of physician workforce, including traditionals and new ones, susceptible to positively impact equity, diversity, and inclusion in service delivery. As objectives, we would like to provide an overview of Scott's medical database, what we call SMDB, at the same time focusing on 3 equity indicators. First, trend in the distribution of female physicians by province over 4 decades. The second one, trend in the number of physicians per 100,000 population in urban versus rural areas by province, also for 44 years period. And the third one, non-official languages spoken by physicians and how that relate to language spoken by ethnic communities. And this is a snapshot. And we're going to look at that in the context of virtual care and the COVID-19 pandemic. Okay, data and methodology. We use the SMDB, as we said. It's a Kai-Hai database that has information on physician specialty, sex, postal codes, languages, English and French, but also non-official languages. For the urban-rural divide for physician, we use a StatsCan PCCF, a postal code conversion file. The mail postal codes, essentially, were used to assign the urban-rural to physicians. Essentially, for the population, we use the census data, and as we know, census data, the latest one is 2016, and we use an adjustment to get an estimate for 2019. For the last indicator, the top 10 non-official language spoken by physicians, actually we identify these languages via SMDB, and we also use 7 major census metropolitan areas, which are those with 100,000 population and more. Okay, now results. This is a general overview. This gives us total physician per 100,000 population in 1976 versus 2019, sorry. So we can see that BC used to have the highest number of physicians per population, and now it's Nova Scotia that has the highest with the highest number of physicians per 100,000. But for each single jurisdiction, we have seen this huge increase in population, in physician per population, per capita, essentially. For the first indicator, which is a percentage of female physicians by jurisdiction, we can see in 1976 it was barely 10%, and now we are talking 43% at the Canada level in 2019, the most recent year. And Quebec is leading the pack among the provinces with a little bit more than half of the medical workforce being female. And if we consider family medicine physicians, even more, we have 57% of physicians who are female in Quebec, family medicine physicians. So huge feminization of the medical workforce in Canada. As for the urban-rural divide, the second indicator, we can see there are 53% more family medicine physicians per 100,000 population in urban than in rural Canada, 136 versus 89. So basically, that's a huge gap. And we can see Quebec has the lowest gap. That's mean Quebec did a great job servicing its rural population. And the highest gap was in PEI, where actually the rural population has much lower service. Okay, in terms of the third indicator, non-official language concordance between patients and provider. We know language barrier is one of the factors limiting access to physician services in Canada. And this issue is becoming more topical due to the diverse ethnicity of the Canadian population, the COVID-19 pandemic, which hits mostly ethnic population, and the increased use of virtual care. So it's essential to provide decision makers with reliable and up-to-date information on these key characteristics of the physician workforce. And we have this medical post article, physician leaving patients due to language barriers. So that's a recent article, October 28. And CPSO, the College of Physicians and Surgeons of Ontario, was involved in this case, and there was a review board that supports a CPSO decision in this case, where doctor left patients due to language problems. So that's a serious problem and it's topical. So I know it's a busy table, but what we can get from this table is that the family physician per 100,000 population non-official ratio is generally adequate, in the sense that we have enough physicians speaking non-official languages. It's about the distribution of those physicians. For example, there are some places, there are a lot of them. For example, we can see in Montreal, we have barely 14 physicians per 100,000 population speaking Arabic, while in Toronto, Winnipeg, we have a very, very high ratio. So we need redistribution here. And that's the same thing, for example, for which if we take Punjabi in Montreal, just 23 physicians speaking Punjabi per capita, non-official language. And Vancouver, same thing, just 79 physicians for Punjabi, while we have in Ottawa 592, much higher than needed. So there is a case for redistribution here. And that's a key factor to consider. Interpretation policy implications in general, with increased feminization of the medical workforce, access to physicians in a pandemic is conditional on childcare availability. We have seen that in the first wave of the pandemic, where the whole economy was closed and workers cannot get access to schools for their kids, to daycare. And it was a problem. And the medical workforce was impacted also due to the high presence of female in the medical workforce, obviously. So that's very important to take into account in policy making. And we have seen the rural areas are underserved, but we need to look at other healthcare professionals as well, like registered nurse practitioners, and also virtual cares. All that can play a role in providing healthcare in rural areas. And for the languages, we need to, resources can be allocated to decrease language barriers, for example, face-to-face or telephone interpretation services, like Winnipeg Regional Health Authority with services in 32 languages face-to-face and 200 languages via telephone, and supporting non-official language medical students in their clinical placements where non-official language physician population ratios are low, that's something also that can be relevant in terms of matching non-official language physicians with their ethnic community. So that's essentially the presentation for today. Now we have a questions period, and the questions can be in either English or French. So thank you very much for your time.